We're going to talk a little bit about mass disasters and emergency management. So, I don't expect any of you to be proficient in any of these triaging and preparedness type things, but I do want you to be aware of them. We're seeing more and more of these type of questions pop up on the NCLEX because it is something that is becoming more and more prevalent in our nursing preparation. So, it makes sense that we'll address it here. So, the first thing we're going to talk about is sort of the difference between a disaster and an emergency. And sometimes they seem like they're the same thing. But when we're talking about actual disasters, we're talking about things that are sudden mass destruction, mass damage, unfortunately, quite a bit of death. So, we have those kind of divided into natural occurring, what kind of insurance writers consider acts of God, right? Hurricanes, tornadoes, things like that, maybe disease outbreaks. And then we have man-made, which are obviously our mass shootings that we're seeing more and more of, acts of terrorism and wildfires. So 80% of wildfires are actually started by humans, while some do occur due to lightning strikes and such. We do still consider those to be man-made. And then we have emergencies. And so those kind of fall into a different category of unforeseen circumstances where we have immediate things we got to do to fix it. So, whereas disasters are something that completely disrupt our normal functioning, right? The tornado takes out the house or the flood, something like that. Where emergencies tend to be handled more by our emergency management system, the number of victims tends to be smaller. So we think of that as something more what we would get in our emergency departments, right? Car crashes, some type of building problem that happened where multiple people, fell downstairs, things like that. Whereas a disaster rarely involves just one person. And this is something that can't really be handled by local responses. This is something that is overwhelming what our normal management system could handle. And again, the example there was the train derailment, right? So remember in East Palestine not that long ago, there was the train derailment. It had hazardous chemicals. And to this day, it's been several years, and they still are mitigating the effects of that disaster. So, all registered nurses are actually required and expected to have knowledge based on what our competencies are set by the World Health Organization and our International Council of Nurses. So, this is the collective have decided that these are the things that we are responsible for doing. And all of us that have RNs. That is recognizing our disaster potential, knowing when a disaster has happened, how do we protect ourselves, our community, our family? What are we supposed to do? What's our role in this whole thing? And then within our scope of practice, we are supposed to respond. So during COVID, anyone with an RN was contacted by the Ohio Board of Nursing, and we were asked these questions, such as, what is your availability? What are your specialties, right? What are the things that you are proficient in? Where are you able to travel? Do you have access to these things, right? So I filled out my survey and there were all sorts of things. Are you proficient in ventilators? Do you know how to do central lines? Are you proficient in triaging? And have you had any hazmat training? Those type of things, right? So we're all required and have to have this basic understanding. So in your book, actually, there are 10 nursing competencies that are all laid out, and they're very simple, but there are 10 things. And just again, because you are going to have your registered nurse license at some point, you need to understand what your obligation is. So when you do your competencies and you do your continuing education credits, a lot of times there'll be an option to go ahead and review disaster management and response. So your book calls it a disaster continuum. It can be referred to as emergency management. So basically, how do we get our resources where they need to be from the very beginning, which is we have meetings to make plans, all the way to the end to what people are signed up for what part, right? Your book breaks it into five. Most of the things that I'm familiar with called prevention and mitigation. We kind of put those together in one, which is what we're going to do here, but you can space them out a little bit if you'd like. So The book calls your first step in the pre-impact, meaning this is what we're doing before something actually happens. So this is our plan to minimize any type of damage that would happen. So what do we do? So all these things that are going to be in yellow in the next slides, those are our nursing role. What are we responsible for doing? So preventing disease and mitigation. So we are good at assessing, and we're going to be looking at our environment and where we're at in our community, and we're going to assess for what could happen, and we're going to raise some awareness, maybe bring some ideas to the table on how to fix it. So an example of this would be, think of the suburbs of Columbus, right? They are plowing down fields and they're building houses faster than they can really be sold, right? They're just constantly building. So when we do that, we are altering the terrain of the natural environment. We're taking away trees, we're rerouting water, we're putting in more pavement. So we know that we're at a risk for flooding, we're at a risk for tornadoes, we're at a risk for several things based on what we're doing. And we need to have a plan for that, right? We have retention ponds, we have, basements in our homes, things like that. When it comes to the mitigation, then we're looking at how are we going to prepare for disease, right? How are we going to limit what happens if disease happens? So what do we do? So our prevention is we provide immunizations, and we have a plan. How do we isolate people that come in contact with it, right? And so then how do we mitigate it? How do we keep it from getting worse? Again, we have these overpopulated areas, right? We have group housing, we have incarcerated population, we have schools. So how do we kind of divide a plan if we do have an outbreak on how to keep it from destroying the entire population? We know really a lot about this since COVID, don't we? Disaster preparedness also falls in this pre-impact, and that is our policy. So we've done our job as nurses to assess. So then we have to come up with some policies. Everybody has to be on the same page. We need to have a written plan that's accessible, that we submit, that everybody takes a look at. So our job is we need to make sure we know those plans and protocols, and we need to participate in drills, right? And there's a little kiddo in that picture there, practicing for a drill. That's our job, right? And when we go to our community settings, we need to make sure they have this plan, they have access to it, all the employees are aware. And we need to make sure that we have explain, right? So when you're listening to the radio and they have that horrible, horrible screech, that's the test of the emergency management system, the broadcast system. We need to make sure people understand, right? That when you hear that, make sure you listen. Is it a test, right? In Ashland County, we do the tornado sirens on the first Wednesday of the month at noon, right? And so we have to explain to people who are not familiar with that, oh, it's fine, it's just a test, right? But then we have to understand, if it wasn't a test, then what does that mean? What do we do? The one that's kind of the most hands-on then is our response. And this is during the impact. This is what we call our search and rescue phase, or like our immediate phase. This is where we're focused on getting people what they need during the disaster, during the emergency, whatever it is, whether it's finding them food and shelter, whether it's getting them the health care they need, whether it's removing them for a situation. And our job is to, along with assessing the physical needs, we got to assess the mental, the anxiety, the fear, the panic. We can assess with triaging, which is where do they need to go, where are our zones we need to be, first aid, making sure we've got good communication, and really just focusing on keeping calm, making sure that we are there hands on. And we're also are going to be working very closely with other organizations doing the same thing so that we can have a coordinated response, right? So Red Cross, all of our, our police officers, our firefighters, if it gets to a bigger level, FEMA, coordinating with them, right, along with our public health department. Then we get to our recovery, which is post impact. And this is when we're trying to get back to our new normal. So this is where we focus on rebuilding, on replacing things, on getting our schools up and running, on getting our work back and running, getting the power turned on, getting our clean water, right? Maintaining the health, and kind of seeing where we're at, right? Making sure if we don't have good water, we're going to be assessing for disease and waterborne illnesses, right? Think of 9/11. Think of the huge response that we had from that, and how we've had a continuing rebuilding and repurposing, and assessing the volunteers who are now coming down with illnesses from the exposure to chemicals. So the disaster recovery phase can be very much ongoing. It's not just oh, we're there, we fixed it. We're going to continue to address the needs of those affected for a long time. in rebuilding those communities. When we are in the impact stage, which is our response, our emergency response, our disaster plan, we're going to use something that's called the START method. And that is simple triage and rapid transport. So what this uses is it makes sure that we get the people the care they need without taxing one aspect of our response system. And this is under normal circumstances, meaning this is when we are not talking about mass catastrophe type situation. This is under normal circumstances. This is not radiation. This is not whatever. We can use this for different things, but what this is designed for is the bus accident. This is designed for the car crash. This is designed for things that are pretty much containable and accessible, right? So we're going to use a tagging system, and it's going to be red, yellow, green, and black. So our red is going to be those that need intervention immediately, right? Without intervention, they're going to have some catastrophic effects. So we use this for people who are bleeding out, in shock, not able to follow simple commands, their respiration rate is high. Those are type of things we use for red. For yellow, these are our people that are not able to leave, right? These are our broken bones that they're not able to walk. These are our injuries that are not having to do with immediate medical attention, right? So they require medical attention. They are injured. Maybe they can't leave the situation, but if I move on to the next person, they're probably not going to die. Okay, that sounds terrible, but that's the way it is. Whereas the red, if I walk away, you are definitely going to be in severe distress, right? Our green are what we call our walkie-talkies, and these are the ones that are injured. These are our bumps or bruises or scratches, maybe our broken arms, things, but we can still walk. We can still get to a safe place. That doesn't mean we put them in a corner, we forget about them. We don't want to lose track of them, but we know that we've looked at them, we've taken whatever measures we need to do to assess, and we feel pretty confident that they can walk themselves away while we go on to the next person, right? And then we have our black. So black are the people that unfortunately are already expired, or the people that are not expected to survive. And so we kind of use this as if there is no pulse. If we kind of open their airway and we do, I mean, just a quick intervention, if the breathing doesn't come back with a simple intervention of repositioning, moving the airway, then we count it as a black tag, which is there is nothing more that we can do. And there's other people in the red category or the yellow category that could be helped if we went back and helped them. If we stay with the black tagged person, they're not going to really have a good outcome regardless. If for some reason you do a quick intervention and they do begin breathing, then obviously we call them a red tag and we proceed, right? They become our focus. But unfortunately, it's one of those where we have to have limited resources, right? And so we have to make sure we address them as they go. If there is a mass casualty event that is over 100 people, we're talking really, really difficult situation and circumstances here. Then we kind of go to the principle of the greatest good for the greatest number. So let's say that we had some type of I don't know, nuclear type situation, right? Or even probably on 9/11, they went to this type of thing. And that is, we reverse that. If you are able to get out, if you're able to move yourself, if you have a very good chance of survival, those are the people we're going to get out first. So we're going to get all of them first. Then we're going to find those people that have the minor injuries, the broken bones, things like that, that we know are going to be okay. We assume we're going to be okay. And then if we have time and we're able to go back in, then we're going to get the people that are most severe. This is not obviously something we ever want to have to deal with, right? But again, if we are looking at more than 100 people, we need to make sure that we can get the most kind of bang for our buck as far as the resources go. So if we only have a certain number of volunteers that are going in and first responders, they're going to help the most by getting people out that are ambulatory and maybe not those that are kind of pinned or trapped or having severe. If we have this type of event, then we kind of have to divide where we're working into zones, right? So the safe zone where we're going to kind of hold everybody, where we're going to make decisions, our command post, that's what we're going to call our cold zone, our safe zone. The warm zone then is going to be our yellow zone. That's where we're going to have, we're close to the site of the nuclear explosion or whatever it is. That's where we're going to kind of have our control area of decontamination, right? That's where we're going to kind of make sure before we move them where everybody else is to the mass, to the general public or to where the survivors are, we have to make sure that they're safe to proceed to there. And then we have the hot zone or the red zone, which is going to be the area, the actual impact. Again, so if you're thinking of like 9/11, right? Obviously, the towers were going to be your hot zone. Then you're going to have, the couple city blocks around that. That was going to be your warm zone where they were checking people, hosing them off, doing all those type of things. And then you had, across the bridge, across the river, there's where you had your safe zone where you're moving your survivors to. Here's an example of what tags look like, and you can put them around their neck. You can have them hold on to it if they're able. And basically, you were going to fill this out. You're going to fill out real quickly. Are they breathing? Yes, no. Do they have good perfusion? Yes, no. What's their mental status? Do they have any type of contamination? And then they're going to move them on. And again, this is a way to address everyone. If you think of when there was Hurricane Katrina, when they would go to all the different homes by boat, they would go in the house, they would write an X, they would write a number, they would write a circle, how many people they removed from the house, how many people were expired in the house. So again, just a way for everyone to not overstep and overdo so that we're addressing the situation, moving on to people who haven't been addressed instead of doubling up. Another thing that we kind of have to focus on here is the topic of terrorism. And we kind of think of two different things of conventional and our non-conventional. So we think of anything that is going to be a threat of violence, and it's used to instill fear or try to get a goal attached, right? Try to force somebody to do their will. If you look in your book on section 7.3, it kind of expounds on this a little bit, but this is for sense of purpose. A conventional weapon, we're thinking of something we typically would with bombs, guns, explosive devices, where our non-conventional are going to be our chemical weapons, biological weapons, nuclear weapons. So we've really had to expand on this terrorism, right? To things that are cause and effect. Is it going to be a cause and effect? Something causes damage, boom, we see it. Or are we looking at something that is maybe an invisible or something that's going to down the road cause problems? Bioterrorism then is what we use to cause illness or death, right? That's what it's used for, whether it's targeting a population of people or livestock, whether it's contaminating a large food source. But the purpose of this is to destroy, mass devastation, right? The three different things that are kind of the most familiar, I guess, are our different agents. So we have bacteria. A very common one that we hear about is anthrax, right? There was a scare of that. It's spread by spores. If you remember, they had anthrax that was being mailed to people, and so for a while, all mail had to be screened because if there any white powder or spores in it. It is naturally occurring. Of course, it occurs in the soil, and so it's very easy to spread. But that bacteria then can cause a lot of illness. Viruses, we have the threat of smallpox, right? We have the threat of Ebola. These are very infectious diseases. We know that we have tried to eradicate them, but they could be used as a biological weapon. And then we have toxins, right? And botulism is both a bacteria and a toxin, right? It occurs in expired food or ill-prepared food, but it also can be a toxin. It's a neurotoxin, which can cause death very quickly. So again, these are the type of things where it's not pleasant to think about, but we do have to make sure that we're aware of it because we are living in times that this might be something one day, God forbid, we come across. The hardest part with the bioterrorism is, again, it's not that gunshot wound, right? It's not that explosion. This is tasteless, it's odorless, it's colorless many times, and it's very difficult to start to pinpoint what happens. So if you think about your community, think of all the different places that you would go if you needed healthcare, right? You have urgent cares, you have ERs, you have different hospital systems, doctors' offices, clinics. So it's very difficult to kind of get a grasp on where we're at and kind of do some tracking if it's something that is being seen multiple places. So our job as nurses with this is to do surveillance, right? To make sure that we are doing our contact tracing, again, which we got really good at during COVID, but really kind of getting an idea and doing a community assessment, a public health assessment, and seeing what changes we're seeing. We're seeing a common theme, a common thread, and kind of working through that. Real quickly, nuclear terrorism. I think we've had a threat of this for quite some time, which is when we have a non-conventional, a lot of times using radioactive material that can cause fallout. Now, this could be something that is deployed, or this could be something such as an attack on an existing nuclear power plant, something like that, where that radioactive material then, if you think of Chernobyl, if you think of those type of events, would that have had fallout for it'll be for hundreds of years, so that half-life of that radioactive material finally does dissolve. So we can't do much individually when it comes to terrorism. What we do need to know is we need to prepare ourselves. We need to do our education. We need to make sure that we are performing our assessments. If it would come to it, administering administration, to participate in drills, to make sure that the community knows what's going on, to participate in things such as vaccinations, or in the event of a nuclear or I'm sorry, a biologic weapon, administering, whatever antivirals or whatever we need for an antidote. So there's not a lot that we can do individually, but education, assessment, and keeping ourselves prepared what to do in some an emergency is pretty much our role. If you look in your book, on table 7.1, it's got a 2-page chart on different types of disasters, what type of injuries you're commonly going to see, and then what are the nursing implications of that. So I want you to look over that chart. I don't want you to memorize it by any means, but I do want you to be aware of, like, what type of injuries do we typically see with tornadoes, right? What type of things do we typically see with this type of disaster? And then again, what are our nursing considerations? Because then ultimately we need to know what's our job? Like, what are the things we are supposed to do if we're faced with this? All right. So in your module, there's also going to be a case study that I'd like you to complete. It's very straightforward. It explains a train derailment that ran into a bus. And so it gives you different patients, and it's going to give you a little bit about their vital signs, a little bit about their assessment data. And I want you to say, using that START method, right, that rapid triage, what category would you put them in? Red, yellow, um, green or black? And then I want you to say why. What is it that you used? What is it that made you think that you would do that? Okay. And then there's 5 questions I want you to answer. And this is kind of that critical thinking, right? Kind of putting this all together. How do you feel about using this system? What would you do if you couldn't actually see anything wrong with somebody? What would you do if you disagreed with somebody? Right? Those type of things. So I want you to answer, and it's broken down into a Word document. You can just type the answers right in there if you'd like. What color did you give this person and why? And then I want you to kind of answer this question. So if you had to use this, how would you feel about it? How would you feel about walking past somebody and then having to go to the next person and kind of leaving that person behind? So just some reflection to kind of think about how you would implement this. And then kind of submit that on Canvas, and we'll have a chance to kind of go over in class a little bit and discuss why we did certain things, why we thought certain things, to kind of get a little more familiar with that whole protocol. So I put 2 links in the module. One is for, these are from .gov site, so they are legit. One is for adults and one is for pediatrics. So you can use these algorithms and kind of go through, and that should help to ease your assessment. So thank you, and I'll see you soon.